It's always important for me to establish a very close collaboration with the primary care physician in the treatment of the patients, primarily because there's so many things going on. Patients are much more complicated these days.
All right. Have you had a stroke? Can you not take your medicines? Do you not want to take Coumadin? Are you scared of Coumadin more than you're scared of AFib?
To me, the most important is the initial visit. My philosophy is I don't leave the room until all the questions are answered and the patient really understands what I think is going on and what plan I think we should devise in order to first diagnose it and then treat it.
As far as AFib goes, and what do we need to do? I reiterate it over and over again. Are you having symptoms? If the answer is yes to symptoms, then you have to start looking at, all right, structurally and evolutionarily, where are we in our AFib?
More often than not, you have a patient who has multiple underlying problems, all of which can affect atrial fibrillation.
And if he's in paroxysmal, all right, now we know that 95% of the time those triggers are in the pulmonary veins.
Sometimes there's heart disease, underlying heart disease, which also may influence atrial fibrillation.
Is there some other organic problem with the heart that needs to be addressed at the same time?
Sometimes radiofrequency catheter ablation or catheter ablation using radiofrequency energy may not be as effective from patient to patient, and sometimes actually freezing the tissue is more effective.
The new Mid-America Heart Institute is unique.
We have eliminated the line that divides the cardiologists from the surgeons themselves.
It allows for us to create an environment of collaboration.
We've actually become a team composed of cardiologists and surgeons rather than two separate groups.
The facility itself is beautiful and it's impressive to see, but it's not the walls and the floors that make the difference. It's actually the people.
Even though we're a very large group, what we can guarantee is that any type of test that can be done will likely be performed by a cardiologist who really specializes only in that test. Cardiologists who only read echocardiograms. We have cardiologists who only do stress tests. We have cardiologists who only do intervention.
I think that everybody that comes here gets a sense that they got fantastic care.
Treating the patient, not the illness, trying to design some sort of therapy that will make the patient's life better.
I mean, it goes all the way to the housekeepers, the nurses, the doctors, and administrators. I mean, everybody kind of seems to be on the same page all the time.
What we have is availability of multiple tools, and with that, then we can actually tailor how we're going to approach the patient or how we're going to approach their treatment of atrial fibrillation.